Hello to all. On behalf of myself and my collaborators, thank you to the organizing committee for inviting me to present our data from our pilot study of nivolumab in combination with frontline neoadjuvant dose-dense paclitaxel and carboplatin chemotherapy in patients with epithelial ovarian cancer. These are my disclosures. So as most of you know, the prognosis for patients diagnosed with high-grade epithelial ovarian cancer remains poor, with less than 20% of patients remaining disease-free. There has long been speculation that the immune system may play an important role in disease control, as signified by the fact that the presence of tumor-infiltrating lymphocytes, or TIL, is associated with improved survival. This led to great enthusiasm for the clinical potential of PD-1/PD-L1 blockade in this disease, but sadly, the response rates to single-agent PD-1/PD-L1 blockade has been extremely modest thus far, on the order of 10 to 15%. Given the preclinical data that suggests that chemotherapy may sensitize tumors to checkpoint blockade and the success of chemotherapy plus PD-1 blockade in non-small cell lung cancer, we hypothesize that the addition of nivolumab to carboplatin and paclitaxel for the upfront treatment of epithelial ovarian cancer would improve patient outcomes. Thus, we developed a pilot study to assess the efficacy of neoadjuvant nivolumab plus carboplatin and dose-dense paclitaxel for the upfront treatment of patients with epithelial ovarian cancer. The study schema is displayed here. Patients were treated with 3 to 6 cycles of standard dose neoadjuvant carboplatin plus dose-dense paclitaxel plus flat-dose nivolumab. Patients then underwent interval debulking surgery, followed by another 3 cycles of adjuvant treatment. If there was no evidence of progression, patients could then be treated with monthly flat-dose nivolumab for up to 1 year. Our planned enrollment was 20 patients, with a predetermined safety assessment after 10 patients were enrolled. The primary objective of the study was to determine the safety and tolerability of dose-dense paclitaxel and carboplatin with nivolumab. Dose-limiting toxicities were defined a priori and included toxicities that prevented or delayed interval debulking surgery, defined as inability to perform interval debulking surgery within 6 weeks of cycles 3 to 6. Secondary objectives included the complete gross resection rates as documented by the treating surgeon at the time of IDS, the pathologic complete response rate as documented by the study pathologist, as well as duration of progression-free survival and overall survival. Translational objectives included assessing changes in the tumor microenvironment pre and on treatment. Patients were eligible if they had newly diagnosed high-grade epithelial ovarian, primary peritoneal, or fallopian tube cancer, for whom neoadjuvant chemotherapy was thought to be the most appropriate initial treatment with a good performance status and adequate organ function. Of note, patients with low-grade histologies or carcinosarcoma were excluded. We enrolled a total of 21 patients. 1 patient had a grade 3 infusion reaction to nivolumab and was thus ineligible for the primary endpoint and was thus replaced. The median age in enrollment was 64, with a range of 38 to 77. The majority of patients had high-grade serous histology and stage 4 disease. The results of germline genetic testing were reflective of epithelial ovarian cancer population, with 19% of patients carrying a pathogenic alteration in BRCA1 or BRCA2. In general, carboplatin, paclitaxel, and nivolumab was well tolerated. The most common treatment-emergent adverse events were rash, fatigue, arthralgiomyalgia, diarrhea, and pruritus. High-grade adverse events, grade 3 and grade 4, were rare. In the 20 evaluable patients, there were 2 dose-limiting toxicities. 1 patient had grade 4 pneumonitis that was at least possibly attributed to nivolumab and which delayed her interval debulking surgery. Another patient had grade 4 dermatomyositis, also at least possibly attributed to nivolumab, which also delayed but did not prevent interval debulking surgery. Regarding our secondary endpoints, all patients enrolled were able to get to interval debulking surgery. Overall, 90% of patients had an optimal or complete gross resection, with only 10% of patients having a suboptimal debulking. While we await maturation of our survival data, we utilized a chemotherapy response score as a surrogate endpoint. The chemotherapy response score, as published by Bowman colleagues in the JCO, is a validated scoring system which predicts progression-free survival and is based on the amount of residual tumor in the omentum at the time of surgical resection. 35% of enrolled patients achieved a chemotherapy response score of 3, meaning no residual tumor or scattered tumor foci in the omentum. On the right-hand part of the slide, you can see images from 2 patients who achieved a chemotherapy response score of 3, the best. One BRCA wild type on the top, and one with a germline BRCA2 mutation. In both patients, there was an impressive clinical response on imaging. On the left-hand side, you see their preoperative imaging, their diagnostic imaging, and on the right-hand side, you see the imaging just prior to interval debulking surgery. In both cases, you see resolution of ascites and carcinomatosis, and both patients remain disease-free. Amongst the 20 patients that were eligible for primary analysis at the time of interval analysis, there were 9 patients who had progression of disease. Median progression-free survival was 15 months and a 1-year progression-free survival rate of 70%. Median overall survival has not yet been reached, as there has been only 1 death with a median follow-up of 17 months. We performed multiplex immunofluorescence on pre-treatment and on-treatment formalin-fixed and paraffin-embodied biopsy samples using the Perkin-Elmer Vectra platform, including antibodies directed against FOXP3, PD-L1, CD8, PAN-K, and DAPI. When we compared pre- and on-treatment tumor samples, we noted a significant increase in both percentage of CD8 positive T cells as well as CD8 to FOXP3 ratio, suggesting that treatment with chemotherapy plus nivolumab was associated with a conversion to a more immune-inflamed microenvironment. Here we see similar data presented on an individual patient level. Again, we can note that there was a robust increase in CD8 positive T cells after treatment with chemotherapy plus nivolumab in the majority of patients. It's also interesting to note that there was an impressive variability amongst the patients in the degree of T cell infiltration at the time of diagnosis. Lastly, we did note that there appeared to be a relationship between the chemotherapy response score and the degree of immune infiltration. Here, in the figure on the left, we have displayed pre- and post-treatment tumor samples in a patient who achieved a CRS score of 3, 2, and 1. What you can see here is that in the patient with a CRS score of 3, there is a much more robust immune infiltrate at the time of interval debulking surgery compared to baseline, as signified by the degree of yellow, which is CD8 positive T cells, as well as PD-L1 expression. We also can compare the slides of patients who achieved the CRS versus 3 versus 1. In the patient who had a CRS score of 1, you can see still quite a bit of tumor infiltrate, as well as very little immune infiltrate, very little yellow or turquoise. We therefore hypothesize that response to neoadjuvant chemotherapy plus nivolumab in high-grade serous ovarian cancer is associated with tumor microenvironment and conversion to an inflamed phenotype. In conclusion, neoadjuvant dose-dense paclitaxel and carboplatin with nivolumab was safe and tolerable for the upfront treatment of epithelial ovarian cancer. There were 2 dose-limiting toxicities which delayed but did not prevent interval debulking surgery. 1-year progression-free survival and overall survival rates were commensurate with historical data. On translational studies, we found that treatment with nivolumab plus carboplatin and paclitaxel was associated with a significant increase in CD8 positive T cells when comparing pre- and on-treatment tumor tissue, and was also associated with the degree of chemotherapy response. Additional translational work is ongoing to help elucidate who may benefit the most from the addition of PD-1 blockade to a chemotherapy backbone. I'd like to acknowledge patients and their families, as well as all of my colleagues at Memorial Sloan Kettering, as well as Alexandra Snyder. Thanks so much for your attention.
Welcome. This is Dr. Melissa Hardesty speaking from Alaska Women's Cancer Care in Anchorage, Alaska. And I would like to thank you for allowing me to share the preliminary results of Ovario, which is a phase 2 trial of maintenance niraparib and bevacizumab in the upfront setting following standard platinum-based chemotherapy with bevacizumab. I have nothing to disclose. We all know that advanced high-grade serous ovarian cancer typically recurs following primary therapy, and that this recurrence generally occurs in the first 1 to 2 years of follow-up. The use of tolerable maintenance therapy to prevent or delay this recurrence has been a long sought after goal. The publication of the SOLO-1 data in 2018, which, as you all know, demonstrated a remarkable extension of the progression-free survival for cancers associated with BRCA mutations, gave us hope that this may be an achievable goal and that PARP inhibitors will play a central role. Niraparib is an FDA-approved PARP inhibitor for use as maintenance therapy in platinum-sensitive recurrent ovarian cancer, as well as for use in the recurrent setting for heavily pretreated ovarian cancer with homologous recombination deficiency. Recently, results of the PRIMA trial were published, demonstrating the effectiveness of niraparib monotherapy in the upfront maintenance setting. Effectiveness was demonstrated regardless of HR status. However, the magnitude of benefit was markedly greater in the HR deficient population. The hope is that the use of the combination of VEGF and PARP inhibitors might work even better, especially in the HR deficient population. Avanova demonstrated a clinical benefit and the safety of the combination of niraparib and bevacizumab in the recurrent treatment setting over niraparib alone. And more recently, payola showed improvement in progression-free survival for upfront maintenance using the combination of bevacizumab and olaparib over bevacizumab alone, although the hazard ratio for the HRD negative group was somewhat disappointing. The biological rationale for this combination is that the VEGF inhibition creates a hypoxic environment that leads to suppression of the homologous recombination genes. This theoretically would create a homologous recombination deficient-like environment in which PARP inhibition would have improved effectiveness in a symbiotic way. Ovario is a single-arm phase 2 trial evaluating the use of frontline maintenance niraparib and bevacizumab following upfront platinum-based chemotherapy with bevacizumab. The primary objective is a landmark progression-free survival at 18 months, and the secondary objectives are progression-free survival at 6 and 12 months and safety profile, all of which we will report on today. This trial enrolled 105 women with advanced stages 3B to 4 high-grade serous or endometrioid ovarian cancer who had a complete or partial response following standard upfront platinum-based chemotherapy with at least 2 cycles of bevacizumab. Chemotherapy was allowed to be given in any standard way. 21-day dosing, dose dense, or intraperitoneal were all allowed, and upfront or interval debulking after neoadjuvant treatment was also allowed, but an attempt at surgical debulking was required. Patients were then treated with 200 to 300 milligrams of oral niraparib daily for up to 3 years. Dosing was based on body weight and platelets, and bevacizumab was given at 15 milligrams per kilogram every 21 days for up to 15 cycles total. You can see that most patients were treated with the 200 milligram niraparib dosing. In addition to progression-free survival, other standard endpoints are also being tracked. You can see baseline demographics here. Most of these women had high-grade serous ovarian cancer, and you could see that about half were HR deficient. 2/3 of these were related to underlying BRCA mutations. I would like to point out that this population of women was a very high-risk population, as evidenced by the fact that 63% were treated with neoadjuvant chemotherapy, 21% had stage 4 disease, and almost 40% had only a partial response at the completion of primary therapy. This distribution of high-risk markers is similar to that as seen in the PRIMA trial, and is even higher than the proportion of neoadjuvant chemo reported in payola, and there were more women with only a partial response to primary therapy as well. Here we report progression-free survival at 6 and 12 months for the entire group, and then we break it down by homologous recombination status. In the overall population, there was a 6-month progression-free survival of 90% and a 12-month progression-free survival of 75%. Among the homologous recombination deficient group, which was about half of the patients, the 6-month progression-free survival was 98%, and the 12-month progression-free survival was 88%. For the homologous recombination proficient group, the numbers are 82% at 6 months and 66% at 12 months. The homologous recombination not determined group looks similar to the homologous recombination proficient group, as others have previously reported. As has been shown previously, with the combination of PARP and VEGF inhibition, the incidence of adverse events was high, with almost all patients experiencing some adverse events and the majority having some grade 3 or higher events. Dose interruptions and reductions were common, however, only 25% led to treatment discontinuation. The side effects were as had been previously reported for these agents used alone, with thrombocytopenia being the most common grade 3 adverse event, followed by anemia and hypertension. Overall, no new safety signals were observed. In conclusion, our preliminary data suggests that the combination of niraparib and bevacizumab is an effective combination for use as upfront maintenance therapy to prolong progression-free survival in all biomarker subgroups, as was seen in the PRIMA trial. 75% of women in this trial remained progression-free at 12 months in a very high-risk population of women, 63% of whom were treated with neoadjuvant chemo, and 37% of whom had only a partial response to primary therapy. The rates of therapy discontinuation were higher than are seen for PARP or VEGF monotherapy, but the safety of the combination seems to be consistent with the known side effects of each drug alone, and with dose interruptions and reductions, the majority of patients are able to stay on therapy. Thank you for your time, and we would like to thank all of the investigators and the women who participated in this trial.